we're going to move on to another case. By the end of this podcast, you should be able to explain the structure and function of the rotator cuff, describe the natural history of rotator cuff degeneration, list the contributing components of rotator cuff syndrome, and describe the treatment pyramid for rotator cuff syndrome. So this is Elmer. He's a 52-year-old right-hand dominant male presenting with left shoulder and arm pain that started insidiously 6 months ago. It's diffuse and radiates down his arm towards the elbow. It's a problem mainly when he tries to lift his arm or reach for things, and it wakes him up multiple times a night. Elmer the welder is a smoker with poorly controlled type 2 diabetes. He's tried cannabis for this problem with limited success. He hasn't got any hobbies or recreational activities, and his wife, who's come with him to clinic, says he's just not himself lately. When you examine him, Elmer is somewhat overweight with only mild atrophy around his shoulder. When you watch him move his arm, his scapula wings with the movement, he's stiff in internal rotation behind his back, and his forward elevation is painful after about 90 degrees. His strength is well conserved. He has no neurovascular findings and his neck works fine. He is tender when you palpate his AC joint, and he has some pain with resisted elbow supination. So what tests can we use to sort this out more effectively? As his doctor, you've already obtained an X-ray and an ultrasound. Unsurprisingly, it shows multiple findings. His X-ray shows significant arthritis of the AC joint. His ultrasound shows a full thickness, full width tear of the supraspinatus tendon, thickening and intrasubstance tearing of the long head of biceps tendon, and some thickening of the subacromial bursa. So let's start with the supraspinatus tendon. The rotator cuff is 4 muscles arising from the scapula and inserting on the proximal humerus. They're innervated by branches at various levels of the brachial plexus, arising usually from the C5 and 6 nerve roots. As we've mentioned before in podcast 2, each muscle has an independent function, but also collective functions. The collective functions of the rotator cuff are to keep the humerus centered on the glenoid in all arm positions and to resist the upward pull of the deltoid muscle. Normal shoulder function is dependent on balance between these motors. Rotator cuffs degenerate. Their intrinsic healing ability stinks. You may have a session on tendon, ligament, and other basic science topics. With this, it's more of a tendinosis tendinopathy than an inflammatory process. For most people, the problem starts in the supraspinatus and can enlarge either posteriorly or anteriorly. The natural history of rotator cuff degeneration follows a rough scheme as shown here in the slide. There are many exceptions observed, and not everyone has symptoms at every step, and not everybody gets to the end of the line. But in general, what starts out as bursitis-type pain in the upper 30s can eventually march along to rotator cuff arthritis in the elderly patient group. The other complicating factor here is that rotator cuff syndrome involves more than just the rotator cuff itself. This here is the rogues gallery of assorted problems. Any or all of these contribute to the shoulder girdle pain that a patient can experience, and can be hard to sort out which is causing symptoms and which are silent. We're going to look at all of these except for the subacromial bursitis. If you want to know more about that, check out the bonus material from Carol's first bad day. The first associated problem is AC joint arthritis. This is a small joint with high stresses crossing it, and almost everyone will show degenerative changes on an X-ray. Most people will not have problems. Key clinical features are tenderness to palpation over the joint and pain at that joint with cross-body adduction. If it's asymptomatic, no further intervention is required. So here is our treatment staircase. Elmer does have symptoms, so let's climb the staircase. Step 1 are things that he can do. Step 2 and 3 are things that can be initiated by his primary care physician. So topicals and oral anti-inflammatories. The AC joint is pretty close to the skin, and so these may work for him. A cortisone injection can help with pain over the short to medium term and can help confirm the diagnosis. Finally, sometimes I chop out the end of the clavicle to unload the joint and remove the arthritis on the clavicular side. Next, the long head of biceps runs in the bicipital groove anterolaterally on the shoulder, like you can see in the thumbnail. It's stabilized by the subscapularis, the transverse ligament, and other ligamentous structures as it enters the glenohumeral space. It's not an official part of the rotator cuff, but it tends to undergo degenerative changes or become unstable along with rotator cuff degeneration. It can be hard to tease out long-headed biceps problems from rotator cuff problems clinically, but the image may show abnormalities of the tendon. Attritional rupture is common and is fairly benign. It can also signal the potential for associated rotator cuff problems, so it's worth looking into a little bit. Here comes our staircase again. There are some common themes here. You can actually inject cortisone into the long-headed biceps sheath with imaged guidance, and so that's an option here. Finally, if it's sitting there and causing problems, I can release the long-headed biceps tendon and either let it drop or reattach it at a different site. There is also a role for some physiotherapy here, and it can provide some relief. Now, to the main event, the rotator cuff tear. These occur through a combination of degeneration due to vascularity issues, repetitive use, chronic conditions such as smoking, and sometimes through acute injury. So think back to shoulder dislocations in the middle-aged. Classic symptoms are pain with reaching, night pain, and weakness with reaching. Small to medium tears may demonstrate discomfort with strength testing and a painful arc, where large to massive tears may show an active range of motion deficit and clear weakness. Radiographs may be normal, but with advanced cases, the greater tuberosity may be gone, and Shenton's line may be disrupted with the humerus migrated proximally. Ultrasound is still a good starting investigation. Sometimes an MRI is helpful to guide surgical decision-making or to clarify equivocal ultrasounds. In order to get a good quality ultrasound, the patient has to be able to do a certain amount of active range of motion first, so you may need to initiate treatment before you have a fully explored diagnosis. Here's our staircase. So the injection of choice here would be a subacromial injection to start off with. Note the heavy emphasis on supervised active rehabilitation at really all the steps after step 1. It's kind of the underpinning for this whole process. We've mentioned the scapulothoracic articulation before. Dyskinesis is a dynamic functional abnormality of this articulation. It'll manifest with winging, either with movement only or at rest as well. The scapula is tipped forward, rotated around the front, and it sits lower than normal. So why is this a problem? It's common and it contributes to the vicious cycle of shoulder pain. Pain causes muscle inhibition. The muscle inhibition causes abnormal biomechanics, which then lead to pain. It's addressed through active rehabilitation and rebalancing of those controllers and stabilizers. The final bad actor in this little drama is the cervical spine. Just like the lumbar spine relates to lower extremity orthopedic problems, the C-spine is influential for arm problems. There's 3 issues. First, remember that it's the joint above the shoulder. Second, cervical degeneration is really common. It may mimic a shoulder problem because the C5-6 levels are most commonly affected, or it may exacerbate existing shoulder problems because of comorbid disease. Pain with neck range of motion, pain radiating down to the hand like an electrical shock, midline neck tenderness are all helpful features to suggest C-spine, but most of the time it's not this obvious. We're going to unpack our treatment staircase a little bit, beginning with this supervised active rehabilitation, kind of the ideal model and the philosophy that underpins how I think about this. This is the everything you need to know about physiotherapy for shoulder problems on a single slide. So come back to this. If this is done well, it can provide substantial or complete symptom resolution in about 2/3 of patients presenting with rotator cuff syndrome. It doesn't heal the tear, it recruits the remaining structures and optimizes muscle balance and biomechanics. Even surgery doesn't result in a healed tendon 100% of the time. We've also seen corticosteroid injections on the staircase. This summarizes how I use such injections, and there will be a spectrum of opinions between care providers. There are at least 4 locations in the shoulder girdle that are independent spaces to be injected depending on the scenario. The subacromial space you can do in your office, whereas some of the other ones are best done with image guidance. So Elmer's pretty fortunate and has a good family physician who knows what to do with him. He's also motivated to get better and puts the work in with a good physiotherapist. After 4 to 5 months, he returns to his GP better, but not better enough. On to the last step in the treatment staircase. Deciding on surgery for rotator cuff tear is both art and science. These are some of the indications for surgery. It's important to recognize that the patient needs to be in a position to manage the postoperative rehabilitation, critical to achieving a good result. There are some patients presenting in complex contexts that are going to struggle with this, and this is one of the things that makes it really hard to achieve consistently good results. So, Elmer's GP sends a referral into the local shoulder surgeon. Happens to be me. There's some bonus material that fits in between here, but in essence, Elmer gets his surgical consultation a year later. He's quit smoking, his diabetes is better controlled, he signs up for an arthroscopic rotator cuff repair with management of his AC joint and his long biceps tendon. He captures a cancellation date 3 months later. His recovery is average. He's off work completely for 12 weeks, then does modified duties for another 12 weeks. At final follow-up at 1 year, he's got minimal pain, good function, good sleep, and he's back to his usual happy self. So, another successful procedure. On the right, there's a quick list of summary key points for now and for the future. This case has been pretty meaty, but this is the most common degenerative problem of the shoulder girdle, and it's a good thing to invest some time and effort to understand. The other thing to remember is that Elmer is an archetype. Rotator cuff syndrome is very common in women and in office workers too. The incidence of rotator cuff syndrome in the adult population is about 1% per year, affecting people of all genders and walks of life, and potentially all of us in our future. This is the end of regulation time. You can stop the podcast here if you've had enough. There's bonus content that will be more useful in primary care settings later on in life. This slide contains a little bit more information about scapular problems. You're going to hear about scapular winging, and these are total MCQ bait questions for the LMCC. These are scapular problems arising from specific nerve injuries that result in denervation of specific scapular stabilizers. They're much less common than the functional problems we see every day with painful shoulder conditions. Most often now, these are seen as a result of complications of other surgical interventions. So breast surgeons, radiation oncologists, and ENT surgeons, this is a good slide for you. Now, we need to introduce some real-world facts into Elmer's case here. In reality, there's going to be a big gap between being referred to see a surgeon for any orthopedic problem and actually seeing that surgeon. The rest of this bonus material basically deals with how to be an effective primary care provider for someone like Elmer and how to act collaboratively with the future surgical team to make the most of this gap time. Although supervised active rehabilitation is the mainstay of treatment for many shoulder problems, there are real-world pitfalls. It's unfortunately not anywhere near as simple as writing a prescription and sending the patient out. Some things to think about here: patient factors, primary care factors, therapist factors, shoulder pathology factors, and system factors. Step 4 of the treatment staircase includes a few things that are worth mentioning, but you don't need to know right now. Platelet-rich plasma is the soft tissue magic juice du jour and has its vigorous proponents. I don't routinely prescribe it for rotator cuff concerns because I don't think the evidence is there. It is also not covered by public insurance, and it's expensive. If a patient approaches me wanting to try it, and they have the means, I don't stop them. I suspect the role of PRP may continue to evolve over time as we understand it better and have more consistent formulations. This is the other magic juice currently going around. I'm not involved in the prescription or counseling of medical cannabis products. Anecdotally, some patients seem to really benefit from it, either as a pain reliever or as a sleep aid in the context of rotator cuff pain. There is a lot we need to figure out about the effect and delivery of cannabinoids and related products. In the end, there's 3 things to remember about Elmer. First, just because he's been referred, he has not yet been seen by the specialist, and the care ball is still in your court. Second, Elmer has health issues that need addressing if he's going to get the best possible surgical outcomes. Finally, you can advocate for Elmer if you feel his situation is deteriorating and would benefit from an expedited consultation. These are among the holding pattern care maintenance activities that you can consider. You can look at continued pain, sleep, and mood management, and if his symptoms change, get a new X-ray or ultrasound. Second, there are things that need to get done to get him ready for surgery. Surgery is good, but it's not perfect for this problem. Negative prognostic factors include size of the tear, chronicity of the tear, patient age, active smoking, and poorly controlled diabetes as some examples. Elmer's a smoker. His diabetes is not well controlled. As you go through the rest of the foundational courses in your med school time, you'll have a better context to understand the systemic health effects of these two very common conditions. For our purposes, they are both bad for the shoulder in addition to everything else. Addressing these as much as possible prior to surgical consultation helps optimize the patient and avoids downstream delays and poorer outcomes. So this is the end of the bonus material for this case. You not only get a real-world view of Elmer, but we also earn our collaboration badge in the CanMeds flower.